and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through a few papers across a span of an individual author. So the individual author is essentially the anchor. It doesn't mean that this author is the primary on all of the papers that we'll talk about. I just want to talk in the general direction of how clinical reasoning seems to occur. Now, I'm going to try to do this and get it to focus. So for those who are watching, maybe you'll see it. It's not working. Can't quite get it to do it. There you go. Maybe you'll see that. Maybe you won't. It's Dr. Jonathan Sherbino. So Dr. Jonathan Sherbino is at McMaster. He is the program head. I believe, is he program head? Well, he runs Merit. He also I think he's the program head of a few things, or not necessarily a few things, but he is a well-accomplished individual. He has been heavily involved in the development of competency by design, the CanMEDS framework across time. I've had the opportunity to have good conversations with him, a very, very intelligent and kind individual trying to help improve education methods within health professions education, health science education. So I'm going to just scroll through. So I showed you that that's what I'm looking at. One of the first things that I want to do, there's a paper from 2012. I cited this in I believe I cited this in my thesis. I don't remember 100% for sure. The title here, The Relationship Between Response Time and Diagnostic Accuracy. So Dr. Sherbino was the primary on this one. Purpose, and I'll read. Psychologists theorize that cognitive reasoning involves two distinct processes, System 1, which is rapid, unconscious, and contextual, and System 2, which is slow, logical, and rational. According to the literature, diagnostic errors arise primarily from System 1 reasoning, and therefore they are associated with rapid diagnosis. This study tested whether accuracy is associated with shorter or longer times to diagnosis. Method. Immediately after the 2010 administration of the Medical Council of Canada Qualifying Examination, MCCQE, Part 2, at 3 test centres, the authors recruited participants who read and diagnosed a series of 25 written cases of varying difficulty. The authors computed accuracy and response time for each case. Results: 75 Canadian medical graduates of 95 potential participants participated. The overall correlation between reaction time and accuracy was negative 0.54. Accuracy then was strongly associated with more rapid response time. This negative relationship with RT held for 23 of 25 cases, individual and overall, when the authors controlled for participants' knowledge as judged by their MCCQE Part 1 and 2 scores. For 19 of 25 cases, accuracy on each case was positively related to experience with that specific diagnosis. A participant's performance on the test overall was significantly correlated with his or her performance on both MCCQE Part 1 and Part 2. These results are inconsistent with clinical reasoning models that presume that System 1 reasoning is necessarily more error-prone than System 2. These results suggest instead that rapid diagnosis is accurate and relates to other measures of competence. So what's the point here? The point basically, or the take-home, is it seems that if somebody's able to answer faster, they're often more accurate. System 1 and System 2 type stuff is it's kind of like economic decision-making, really, where it came more from with Daniel Kahneman and Amos Tversky initially, and Kahneman continuing on after Tversky had passed. So it's not necessarily in clinical decision-making, it's more economic. So there might be a fundamental reason to think that the quote-unquote irrationality of a consumer may be less identifiable in a medical professional who's going to be quite knowledgeable and accurate. So that's at least a possibility. But the other thing is that if people knew more, they were more accurate. If they knew about the specific diagnosis that was being looked for, then they were more likely to get accurate and more likely to do so fast. So speed seems to actually relate highly to accuracy with diagnosis, and it also seems to rely on previous experience with that specific diagnosis. So that wouldn't necessarily line up with an approach that asks physicians to slow down to increase accuracy, as it doesn't actually seem to, at least in this narrow experiment, relate to that. It doesn't seem to show that. I'm going to keep going down here. This is going to be a 2017 paper, How Expert Clinicians Intuitively Recognize a Medical Diagnosis. So I think this one's got, oh no, the abstract's exceptionally short, so I'll just read the abstract really quickly. Who is the primary? John E. Bush Jr., MD. Dr. Sherbino is the second author, and Dr. Norman is the third author, so Jeffrey Norman. Abstract research has shown that expert clinicians make a medical diagnosis through a process of hypothesis generation and verification. Experts begin with the diagnostic process by generating a list of diagnostic hypotheses using intuitive, non-analytic reasoning. Analytic reasoning then allows a clinician to test and verify or reject each hypothesis, leading to a diagnostic conclusion. In this article, we focus on the initial step of hypothesis generation and review how expert clinicians use experiential knowledge and intuitively recognize a medical diagnosis. So, the concern within the first paper in evidence-based medicine was that intuitive approach. They wanted to get rid of it. They not necessarily get rid of it, but maybe minimize it and use more of the evidence, large-scale evidence, large epidemiological evidence in favor of the expertise of the practitioner and their previous experiences. So at least it seems, now this is more of a review paper. It's probably more of a narrative review. It doesn't say in the abstract, but it's not an experiment. It's communicating the bulk of observation in the literature that would already be there, at least as a pattern. So, I'll look at this one really quickly. So Dr. Sherbino has another one, ineffectiveness of cognitive forcing strategies to reduce biases in diagnostic reasoning, a controlled trial. To read here, the objective cognitive forcing strategies may reduce error arising from cognitive biases. This is the first experimental test to determine the effect of CFS training in medical students. Methods: students were allocated to CFS training or control during a 4-week emergency medicine rotation. Number equals 191. At the end of rotation examination, the students were tested using computer-based cases. Application of CFS could enable reduction of diagnostic error as evidenced by identifying multiple correct diagnoses for the 2 cases prone to search satisficing bias, SSB, and uncommon diagnoses for the 2 cases prone to availability bias. 2 false positive cases were included to test for possible over-searching. So they set it up so that there were certain type of biases that were more likely to show up. Results: there were 145 students in their intervention and 46 in the control group. For the SSB cases, 52% of students with CFS training and 48% in the control group initiated a search for the second diagnosis. More than half correctly identified the second diagnosis in the CFS group and 48% identified in the control group. The difference was not significant. For the second diagnosis, the false positive cases, 64% of the CFS group and 77% of the control group incorrectly identified it. There were no significant differences between the groups. In the AB cases, only 45% in each group identified the uncommon correct diagnosis. Conclusions: the educational interventions suggested by experts in clinical reasoning and employed in our study to teach CFS fail to show any reduction in diagnostic error by novices. So if you try to reduce bias, if you actively teach people, it doesn't seem to do anything compared to people that you did not do that to, because they're when you look at medical professionals, they are likely going to share certain characteristics. They're going to try to be accurate. If they see anything uncertain, they're probably going to try to go through that, whether or not you explicitly taught them how to do it. They probably implicitly learned how to do it across time. They want to get all the questions right. They want to do the best they can. They want to be accurate. So they're probably just going to learn how to do that anyways, and teaching them doesn't seem to make it any better. Teaching them specific debiasing strategies, rather, doesn't make it any better. I'm going to read something here. When guidelines don't guide. The effect of patient context on management decisions based on clinical practice guidelines. I'm just going to pause here. All right. Yeah, so back to it. Thank you for dealing with that pause. You won't even notice it because it'll be edited. This is an article called When Guidelines Don't Guide, the Effect of Practice Context on Management Decisions Based on Clinical Practice Guidelines. The primary here is Matthew Mercuri. Dr. Sherbino is the second author. Dr. Frank is in there. Dr. Jason Frank has done a lot with CanMeds as well, as I already noted. Competency by Design, he's spoken all around the world. And Dr. Norman is the final author. So I'll just click over to this so I can get the full abstract here. Purpose. This study examines the influence of patient social context on physicians' adherence to clinical practice guidelines. The expert emergency medicine physicians EM and novice physicians EM residents were surveyed using an internet-based program between January and July of 2013. Participants were presented clinical cases and were asked to indicate if they would order or prescribe a specific test or treatment. Cases were chosen from 4 domains where CPGs exist and were constructed to include or exclude a context variable. Both expert and novice physicians' CPG adherence rate in the CV condition was compared with that. In the no CV condition, the CPG adherence rates in CV and no CV conditions were also compared between expert and novice EM physicians. Expert EM physicians, number 28, were less likely to adhere to CPGs in the CV condition compared with the no CV condition, 56 versus 80% respectively, odds ratio 0.32, 95% confidence interval, blah, blah, blah. I don't need to read all that. Experts were less likely to adhere to CPGs in the CV condition when compared with the novice physicians. Expert and novice physicians did not differ in their adherence to CPGs in the no CV condition. Participants were sensitive to both best clinical evidence of benefit as recommended by CPGs and patient context when determining how care should be managed. So what this essentially would support is that without specific training, and now some people may have had specific training, they didn't necessarily screen for that, as far as I can tell, in things like cognitive debiasing or an EBM approach, the better you are, maybe the more experienced you are, the more of an expert you are, the less likely you are to stick simply to the guidelines when there is context variability. So when you notice the variance in the patient, you're just more likely to go with the information the patient is providing you as opposed to the guideline. That's a consistent finding, as far as I'm aware, across time with respect to expert versus novice. Reflecting on diagnostic errors, taking a second look is not enough. That's a paper that my thesis supervisor was the primary on, Dr. Sandra Montero. I'm not going to go into that one. Disrupting diagnostic reasoning. Do interruptions, instructions, and experience affect the diagnostic accuracy and response time of residents and emergency physicians? This is actually my thesis supervisor, Dr. Montero, was the primary here, and this is from 2015. So the abstract purpose. Others have suggested that increased time pressure, sometimes caused by interruptions, may result in increased diagnostic errors. The authors previously found, however, that increased time pressure alone does not result in increased errors, but they did not test the effect of interruptions. It is unclear whether experience modulates the combined effects of time pressure and interruptions. The study investigated whether increased time pressure, interruptions, and experience level affect diagnostic accuracy and response time. Method. In October 2012, 152 residents were recruited at 5 Medical Council of Canada Qualifying Examination Part 2 test sites. 46 emergency physicians were recruited from 1 Canadian and 1 U.S. academic health center. Participants diagnosed 20 written general medicine cases. They were randomly assigned to receive fast, time pressure, or slow condition instructions. The visual and auditory case interruptions were manipulated as a within subject factor. Results. Diagnostic accuracy was not affected by interruptions or time pressure, but was related to experience level. Emergency physicians were more accurate, 71%, than residents, 43%, and responded more quickly, 54 seconds, than residents, 65 seconds. Response time was shorter for participants in the fast condition, 55 seconds, and then in the slow condition, 73 seconds. Interruptions added about 8 seconds to response time. Conclusions. Experienced emergency physicians were both faster and more accurate than residents. Instructions to proceed quickly and interruptions had a small effect on response time, but no effect on accuracy. So again, experts know more, they're faster, you're going to mess them up less. They've learned more, they're more skilled. And adding rules to that probably isn't going to do a ton. It's not going to make them more accurate. Keep going. Understanding the impact of residents' interpersonal relationships. No, don't need to do that. I'm just going to keep scrolling for a second here. Making decisions in the era of the clinical decision rule. How emergency physicians use clinical decision rules. The primary here is Teresa Chan. Teresa Chan is the founding dean of the Toronto Metropolitan University School of Medicine, which is starting up. It's located in Brampton, Ontario. The abstract purpose. Physicians are often asked to integrate clinical decision rules, CDRs, with their own cognitive processes to reach a diagnosis. Clinicians, researchers, and educators must understand these cognitive processes to evaluate and improve the diagnostic process. The author sought to explore emergency physicians' diagnostic processes and to examine how they integrated CDRs into their reasoning using simulated cases with chest pain or leg pain. Method. From August 2015 to July 2016, 16 practicing emergency physicians from 3 teaching hospitals associated with McMaster University, Ontario, Canada, were interviewed via a novel Teach Aloud protocol. 6 videos of simulated patients with chest pain, breathlessness, or leg discomfort were used as prompts for the physicians to demonstrate their diagnostic thinking. Using a constructivist grounded theory analysis, 3 investigators independently reviewed the interview transcripts, meeting regularly discussed identified themes and subthemes until sufficiency was reached. So constructivist grounded theory, essentially what you're doing is you're looking at information, you're looking at as a raw phenomenon, and you are attempting to identify patterns. Those patterns turn into initial codes or categories, and then you will coordinate with the other researchers to refine that. Sufficiency is when no new patterns emerge. So addition of any data, addition of any observation doesn't add any new pattern or any new code or any new category. Results. A model to describe how clinicians integrate their own decision-making with CDRs was developed, showing that physicians engage in an iterative diagnostic process that repeatedly refines a differential diagnosis list. The steps in the diagnostic process were refinement of a differential diagnosis, ordering a hierarchy of risk, the decision to test, choosing the test, and interpreting test results. Physicians applied CDRs when they had already decided to test. Conclusions. To date, CDRs assume a static linear model of clinical decision-making. Please excuse me. I think I got that cough out properly. Findings demonstrate that participants engage in iterative and dynamic decision-making processes that change throughout their patient encounter, contingent on multiple contextual features. Understanding these processes could inform future development of CDRs and educational strategies around these decision aids. So the expertise takes hold. Yeah, sure, there's a guideline, there's a place to start, but the information you gather will adjust your approach, whether you're taught to do it in a strict way and put a given thing at the top of the hierarchy. So clearly I happen to be grumpier more recently about EBM. EBM would put meta-analyses at the top of the evidence hierarchy. It would put RCTs slightly below that, so that's secondary. I believe personal experience or like individual experience is at the bottom. I could be wrong about that, and if I am, I do apologize, but it is considerably below the meta-analysis or the RCT. An expert clinician is going to figure out what should be at the top of the hierarchy, what information should be there, what form of information they're going to adjust as new information comes in. It is evidence, at least superficially, of something that would be well described as a hypothetical deductive approach with iterative processing. So just start from new point of learning, adjust as is required based on new information. Blah, blah, blah. Clinical cognition, binary or continuous. Yeah, I'm going to look at one from 2019, and then I think I'll wrap up the portion where I'm reading here. This is the effect of teaching Bayesian methods using learning by concept versus learning by example on medical students' ability to estimate probability of a diagnosis, randomized controlled trial, abstract the importance. Clinicians use probability estimates to make a diagnosis. Teaching students to make more accurate probability estimates could improve the diagnostic process and ultimately, I'll finish that up in a second. Damn it. Ultimately, the quality of medical care. Just to go back, Dr. John E. Bush Jr. was the primary. Mark Lee, who was the research assistant when I was going through. Jonathan Sherbino is the final author here. Anyways, I'm going to come back here. Objective: to test whether novice clinicians can be taught to make more accurate Bayesian revisions of diagnostic probabilities using teaching methods that apply either explicit conceptual instruction or repeated examples. Design setting. So the explicit concept. What's the best way to do this? Hold on. Explicit conceptual instruction or repeated examples. The explicit conceptual instruction is, this is what this concept looks like. And then they make it obvious. Then the repeated example, maybe they're asking you to abstract. I'm not sure. I'll read more. Design setting the participants. Randomized clinical trial of 2 methods for teaching Bayesian updating diagnostic reasoning was performed. Web-based platform was used for consent randomization, intervention, and testing of the effect of the intervention. Participants included 61 medical students at McMaster University and Eastern Virginia Medical School, recruited from May 1st to September 30th, 2018. Interventions. Students were randomized to 1, receive explicit conceptual instruction regarding diagnostic testing and Bayesian revision, the concept group. Exposure. 2, exposure to repeated examples of cases with feedback regarding post-test probability, experience group. Or 3, a control condition with no conceptual instruction or repeated examples. Main outcomes and measures. Students in all three groups were tested on their ability to update the probability of a diagnosis based on either negative or positive test results. The probability revisions were compared with post-test probability revisions that were calculated using the Bayes rule and known test sensitivity and specificity. Results. Of the 61 participants, 22 were assigned to the concept group, 20 to the experience group, and 19 to the control group. Approximate age was 25 years. 2 participants were first year, 37 second year, 12 third year, and 10 fourth year students. Mean SE probability estimates of students in the concept group were statistically significantly closer to the calculated Bayesian probability than the other two groups. Experience and control, yeah. So anyways, that's just the numbers. Sorry. I didn't read the numbers. Whatever. Although statistically significant, the difference between groups were relatively modest, and students in all groups performed better than expected based on prior reports and literature. Conclusions and relevance. Studies showed a modest advantage for students who received theoretical instruction on Bayesian concepts. All participants' probability estimates were on average close to the Bayesian calculation. These findings have implications for how to teach diagnostic reasoning to novice clinicians. So, something that I've said before is that when you're looking at a previously filtered group in the form of medical students, or say massage students, or say kinesiology students, or osteopathic students, whatever it is, they've gone through a filter. Your ability to see large outcomes of interventions is likely going to be smaller most of the time. So if you are looking for the impact of educational interventions at a more filtered group, such as physicians or physician trainees, you're probably going to see a smaller effect size. The explicit communication of the concept of Bayesian reasoning showed some effect. It was statistically significant, but it wasn't gigantic because the other people, whether it was the repeated example or the control group, were close to the normal probability range anyways. With these being medical students, they've been filtered. They've probably already developed the skill on the way through to do something like rough probability estimate. And adding explicit instruction is the best way to do it, as far as we can tell. Explicit explication of the concept so that they know exactly what it is, and then they can update it and add it to previously learned skill sets. But they're probably already pretty good at this anyways. So teaching them how to do it it does something, but it doesn't do something gigantic. What you're going to see, most people who are going to get through medical education are going to be pretty smart, pretty accurate. If they're more experienced, they'll be smarter and more accurate and faster. So we see that speed of diagnostic is a stronger indicator as a general thing of accuracy than slowing down and being more deliberate. We do see that when observed and when asked in different ways, the description of the processing of the diagnostic approach is hypothesis generation with differentials, revising over time based on new information, increased confidence, decreased confidence, change as is needed. And it seems as though, even though when there's a guideline, the guideline is not the top of the hierarchy when there's another piece of information that gets presented to the physician that should go to the top of the hierarchy. So a predetermined hierarchy of evidence is not utilized or stuck to with respect to actual clinical practice. Or, sorry, it's more accurate to say with respect to the experimentation related to clinical practice. It is possible that in clinical practice there's a difference, but it's not necessarily observed because it is harder to observe these processes in clinical practice. But when experimented upon, it seems like a hypothetical deductive approach, reordering of a hierarchy based on new information when it should go to the top of the hierarchy, suggesting that a predetermined hierarchy of evidence is not going to be stuck to or useful in all cases. What this does is it allows for a fuller description that the actual cognitive approach to diagnostic is, in all likelihood, regardless of how you ask people to do it or how you prime them to do it or how you want them to do it based on policy, it is a hypothetical deductive approach, even if you try to inject a hierarchy and a rule and a preference. It just doesn't seem to go that way. These are smart people, these are accomplished people. Regardless of the health profession that you're talking about, we have the most amount of data available from medicine, because there's a lot of doctors and they're embedded within academic institutions that have research budgets, and this makes a difference. Also, physicians generally would be considered a public good, such that you would want to make sure they are doing things at the highest possible level. So it pays to study how you teach them so that you get good results out of them. Unfortunately, this means that we should decrease our confidence in something like evidence-based medicine. Evidence-based medicine has value because it does have a hierarchy of evidence that, when valuable, is valuable, but it's not always valuable. That's the deal. When it is valuable, it is. When it's not, it's not. So we should just be a little bit more cautious with this, a little bit more careful, and note that when observed in experimental settings, that physicians will shift what's at the top of the hierarchy as far as the type of evidence. The one to think back to is the contextual variance. When the contextual variance is there, the thing that's more important goes, or a new thing can go to the top of the hierarchy, and then they'll adjust against, or not necessarily against, but not in line with the clinical decision-making rule. So thank you for listening this far. Hopefully you've learned something, and we'll talk again soon.